Hello everyone, I'm here to talk about the ARDS lecture, which is Acute Respiratory Distress Syndrome. For Nursing 254, this is Mrs. Narat giving this lecture. The objectives are to describe pathophysiology, etiology, clinical manifestations, and direct and indirect causes of acute respiratory distress syndrome, which we'll call ARDS throughout this lecture. Identify risk factors and prevention methods associated with ARDS. Illustrate the nursing process in providing culturally competent care across the lifespan for individuals with ARDS. Formulate priority nursing diagnoses appropriate for an individual with ARDS. Summarize therapy used by interdisciplinary teams in the collaborative care of an individual with ARDS. Plan evidence-based care and working with the family in collaboration with other members of the healthcare team, and then evaluate expected outcomes for individuals with ARDS. So let's do a little review for acute respiratory failure. So remember, acute respiratory failure occurs when one or both of the gas exchange functions of the lungs are compromised. Functions are, we have oxygenation and ventilation, which is our CO2 removal. When any of these functions are compromised, it can lead to hypoxemia and or hypercapnia. There are two types of acute respiratory failure. There's type 1 or hypoxemic respiratory failure, and type 2, which is hypercapnic respiratory failure. So we have hypoxemic respiratory failure or hypercapnic respiratory failure. Hypoxemic respiratory failure, so that's characterized by a PaO2 less than 60 millimeters of mercury despite supplemental oxygen, with a normal or low PaCO2. With hypoxemic respiratory failure, you have the gas exchange and oxygenation that do not occur because there is a VQ mismatch. Lungs are adequately ventilated but not perfused. Think of like a PE or a shunt, where the lungs are perfused but inadequately ventilated, such as with atelectasis or pneumonia. Or you might even have impaired diffusion, where that occurs at the alveolar level, where either the distance for gas exchange is increased, such as in pulmonary edema, or there's an issue with permeability of the alveolar capillary membrane. Hypercapnic respiratory failure is characterized by a respiratory acidosis. Think hypercapnic. We have CO2 greater than 50 millimeters of mercury and a pH less than 7.35. Hypoxemia may or may not be present. There is impaired ventilation because there's reduced ability of the lungs to adequately expand, causing hypoventilation. Air movement is minimal, and the elimination of CO2 does not take place adequately. Make sure you review the risk factors for acute respiratory failure on Table 27.5, page 499, and review clinical manifestations on page 500, Table 27.6. So what are some diagnostics that we do with acute respiratory failure? We look at ABGs, especially with hypoxemic respiratory failure, you'll find alkalosis initially, and with hypercapnic respiratory failure, you'll find respiratory acidosis with or without hypoxemia. Make sure you also review the H&H, a chest x-ray, and then you collect some sputum samples and sputum cultures. So treatment for respiratory failure, it's not a disease, it's a condition and a result of another type of pathology, disease or disorder. So you really want to look at these patients and treat the underlying cause and the respiratory failure together. Treatment begins, of course, with oxygen. You want to consider that non-rebreather mask with 100% FiO2. Remember, we go to 10 to 15 liters. And then remember, too, the reservoir bag that's attached to these non-rebreathers should be inflated to ensure that the patient's receiving 100% oxygen. It has to be inflated like a balloon. So in cases where supplemental oxygen may not be enough, you would then use your more non-invasive or invasive positive pressure ventilation, which includes BiPAP and CPAP. We'll go into these a little bit further. So BiPAPs, where the patient receives two different pressures, think 2 bi for BiPAP. It receives a higher pressure during inhalation that assists with opening in the alveoli, and then a lower pressure during exhalation that keeps the alveoli from collapsing during the end of exhalation. A CPAP maintains one continuous pressure throughout the respiratory cycle to help keep the alveoli open through inspiration and expiration. So let's do a case study. This is JT Winters. He's a 19-year-old male admitted to the ED after a motor vehicle accident. He was traveling at a high rate of speed and went off the road. It's estimated his car struck a tree at 35 miles an hour. He was not wearing a seatbelt, but his airbag did deploy. He was conscious at the scene. Upon his arrival to the ED, JT's vital signs are temp 99.3, heart rate's 115, respiratory rate 32, blood pressure is 106/54, 93% for oxygen on 2 liters. He's got pain 10 out of 10. States the pain's across his sternum and on his left side. There's broad ecchymosis around the front of his chest, across the front of his chest, and a deformity along his left side in the region of his 5th through 8th ribs. With each inhalation, this part of his thorax moves inward. Someone uses the phrase paradoxical movement to describe what is observed. Upon auscultation, no breath sounds are heard on the left side. Not good. A chest tube is inserted and 400 milliliters of blood is rapidly drained. What's the current problem? Why was the chest tube inserted? What are the expected outcomes and unexpected outcomes? Okay, pause here. Please take a moment to answer those questions. When you're done, you can hit play and you'll hear me answer. All right, so the answers. What is the current problem? It's the hemothorax, the presence of blood in the pleural space. Why was the chest tube inserted? So chest tube placement is indicated if a pneumothorax or hemothorax occurs as a result of chest trauma. The chest tube helps to drain blood from the pleural space. It will also facilitate breathing and help with adequate oxygenation. So what are some of our expected outcomes? So unlabored respiratory effort. Hopefully our ABGs will normalize. Lung sounds would be present throughout all fields. We prefer clear sounds. And with chest tube placement, pleural and skin integrity is intact. So what are some unexpected outcomes? So you could get a tension pneumo. So a tension pneumothorax can occur if air or blood collects in the pleural space and is not removed. So as positive pressure increases, it may cause a mediastinal shift toward the unaffected side, which can result in compression of the heart, vena cava, aorta, and unaffected lung. Tracheal deviation toward the unaffected side is a hallmark sign of a tension pneumo. So you gotta look for that tracheal deviation with any of your pneumothorax patients. It's a life-threatening emergency because left ventricular heart failure and reduced cardiac output can occur. Now you can also get cardiac tamponade, which is caused by excessive fluid or blood collecting in the pericardial sac. So with this, the heart's unable to adequately fill or contract because of the compression of the ventricles. It can manifest as hypotension. You might have muffled heart sounds and distended neck veins, known as Beck's triad. You need to do a pericardiocentesis. So that's the treatment for cardiac tamponade, for all that fluid accumulation in the pericardial sac. So, ARDS, what is it? So, acute respiratory distress syndrome is characterized by non-cardiac pulmonary edema, so non-cardiac pulmonary edema, and progressive refractory hypoxemia. So you have this progressive hypoxemia, resulting in a decrease of arterial O2 despite administration of oxygen at high flow rates. It is a severe form of acute respiratory failure. So something happens that damages the alveoli. There are these inflammatory changes. You have fluid accumulation in the lungs and also in the alveoli. ARDS also triggers an immune response. So the injury causes a release of cytokines, a type of inflammatory protein, which then bring neutrophils, type of white blood cell, to the lung. But problems arise when some of these proteins and cells leak into nearby blood vessels, and via the circulatory system, they're sent throughout the body, causing inflammation in other organs. So This inflammation, in combination with the low levels of blood oxygen, can lead to such problems as organ failure and sometimes multiple organ failure. So really, to understand the rest of ARDS, we really need to understand the concept of what it is and what happens to our bodies. So really try to understand this pathophysiology, because as soon as you understand the pathophysiology, everything else will kind of fall in place with understanding ARDS. So the first general cause of ARDS relates to direct lung injuries. So think about what direct lung injuries are. So these can be from aspiration. So you get the gastric contents that are very acidic, and then they can damage the lung and alveoli. You could even get this with patients who are near drowning. Any sort of oxygen toxicity. So if you have administration of very high amounts of oxygen, and infections. Infections are a direct lung injury, so pneumonia or even tuberculosis, and lung trauma. The second general cause of ARDS includes indirect lung injury. So the current thinking is a systemic inflammatory response that damages the lungs. So some examples of indirect lung injuries include sepsis. That's the overwhelming bacterial infection in the blood, shock, trauma, burns, blood transfusion reactions, inhalation injuries from toxic substances, oxygen toxicity, and acute pancreatitis. So I want to go over the pathophysiology again, just in sort of a quick summary, because I think it's very important to understand the pathophysiology in order to really grasp this concept. So again, ARDS is an acute lung injury resulting from an unregulated systemic inflammatory response to acute injury or inflammation. You have the damaged capillary membranes that allow plasma and blood cells to escape into interstitial spaces. This damages alveolar membranes and allows fluid to enter the alveoli. This fluid buildup inactivates surfactant. Lungs become less compliant. They're unable to provide adequate ventilation and gas exchange. So the gas exchange is impaired, where less oxygen is able to get into the lungs, and eventually less carbon dioxide will move into the alveoli. Finally, you'll get fibrotic changes that occur from all of this damage. So you'll find that arterial levels of blood oxygen will decrease, which will affect all tissues in the body. So as acute respiratory distress syndrome progresses, the fluid-filled alveoli will develop inflammatory changes, which ultimately damage the lung tissue. And then eventually, this lung tissue is replaced by fibrotic tissue, damaged tissue. So oxygen and carbon dioxide exchange is severely affected. You can't move. Eventually, oxygen levels will not be able to increase even when high levels of oxygen are delivered to the patient. You can't even get a pneumothorax or collapse of the lung due to this alveolar rupture. There's also a major impact on the cardiovascular system. We're finding that more with our COVID patients. Blood pressure may initially increase with ARDS patients. The blood pressure will decrease as ARDS progresses. Cardiac outputs decrease due to acidosis and fluid volume deficit. So they're also at risk of cardiac dysrhythmias and fluid and electrolyte imbalances due to the fluid volume imbalances or treatments such as gastric decompression. So as progression of disease occurs, tissue hypoxia is significant. We get metabolic acidosis, and because CO2 exchange is impaired as well as oxygen, you'll have both combined respiratory and metabolic acidosis, which goes into sepsis, and then multiple organ failure and then death. So there are 3 stages of ARDS. We'll go into those here. So we have the exudative phase, proliferative phase, and the fibrotic phase. So the exudative phase occurs within 24 to 48 hours after injury. There's a release of inflammatory mediators and a disruption in the alveolar capillary membrane. So exudative phase, remember, it's within 24 to 48 hours after injury. This is where all the inflammatory mediators are released. That's the inflammatory response. You have that disruption in the alveolar capillary membrane. You have that alveolar and interstitial edema. You have damage to the alveolar cells that produce surfactant. Remember, surfactant responsible for maintaining alveolar surface tension. Manifestations of this stage include tachypnea, tachycardia, and that's a compensatory response to the hypoxemia that's occurring. ABGs reveal respiratory alkalosis. Your cardiac output increases in an attempt to increase blood flow through the lungs. So that's the exudative phase. In the proliferative phase, neutrophils and other inflammatory mediators that further damage both the alveolar and capillary epithelium occurs. Diffusion defects the result. So you have lots of diffusion. The VQ mismatch worsens. You have pulmonary hypertension that occurs because of the occurring vasoconstriction in the lung caused by hypoxemia. So this results in right-sided heart failure due to this increase in PVR, or high vascular pressure in the lung. Fibrotic changes also occur in the lung tissue. Clinical manifestations of the proliferative phase include hypercarbia and worsening hypoxemia. In the fibrotic phase, there's diffuse fibrosis and scarring, resulting in greatly impaired gas exchange. There's pulmonary hypertension that worsens, as does the accompanying right-sided heart failure. Clinical manifestations in this phase include a decreased left heart preload due to the right heart failure and reduced capacity of the right ventricle to deliver blood to the lungs and onto the left side of the heart. So the end result of the fibrotic phase is severe tissue hypoxia and lactic acidosis. So what are the causes? The exact cause is unclear, but it does not occur as a primary process, but follows a number of diverse conditions producing these direct or indirect lung injuries. So a direct injury refers to damage or disruption of the respiratory system. Indirect causes are those processes or disorders that occur outside the respiratory system but have an effect on the lungs. Sepsis is the most common cause of ARDS. Other causes include pneumonia, severe trauma, aspiration, massive transfusions, cigarette smoking, cardiopulmonary bypass, a pneumonectomy, a PE, and drug and alcohol overdose. So please remember those common causes. Clinical manifestations. So initially, you'll have some hypoxemia, tachypnea, respiratory alkalosis, and dyspnea. They'll be very anxious. They'll have a high heart rate. They'll have, remember, this non-cardiogenic pulmonary edema. So when these patients get chest x-rays, you'll see increased alveolar fluid, and it'll look like bilateral infiltrates. So unlike the pulmonary edema you see with heart failure, there's no evidence of increased left atrial or ventricular pressure, which would indicate left-sided heart failure. That doesn't happen here. So that is why this type of pulmonary edema is referred to as non-cardiac. You'll also have adventitious breath sounds. So as the condition worsens, as ARDS worsens, you'll have refractory hypoxemia, worsening actually. So lung compliance continues to deteriorate, continuing to increase the work of breathing. So despite whatever interventions we're doing, they're worsening. There's hypercarbia and acidosis, increasing lethargy, There's a lot of accessory muscle use and retractions. They'll definitely have cyanosis. And then your peak pressures begin to rise. You'll see this especially if they're on a ventilator. Because of that decreased compliance within the lung, it's requiring more pressure to deliver that ventilatory volume. So here is a quick little picture you can use to help with studying signs and symptoms of ARDS. So we talked about this already: tachypnea, dyspnea, retractions, hypoxia, tachycardia, decreased pulmonary compliance. With your ABGs, you're going to have decreased PO2 and an increased dyspnea, which means just that patients do not get better. They can't get better, even with high amounts of oxygen that are delivered to them. So causes, again, trauma, pulmonary infection and or aspiration, prolonged cardiopulmonary bypass, shock, even if that emboli or sepsis. And sepsis is most common. So ARDS and COVID-19, this is not, I'm tempted to add a question on the test this year for ARDS and COVID, but in the past I haven't. So if I do decide to do that and add a test question about ARDS and COVID, I will let you know. But this is good general knowledge anyways, because many patients you are going to see now will have COVID. Okay, so COVID-19 pneumonia. So in pneumonia, the lungs become filled with fluid and inflamed, leading to breathing difficulties. So for some people, breathing problems can become severe enough to require treatment at the hospital with oxygen or even the ventilator, which we're finding that some people just get so bad at home that they can't oxygenate enough and have to come in. So the pneumonia that COVID-19 causes tends to take hold in both lungs. The air sacs in the lungs fill with fluid, limiting their ability to take in oxygen and causing shortness of breath, cough, and other symptoms. Most commonly, it manifests as viral pneumonia induced. So ARDS, remember, you have that fluid accumulation in the lungs, you have shortness of breath, and cough. While most people recover from pneumonia without any lasting lung damage, the pneumonia associated with COVID is severe. So even after the disease is passed, there's lung injury that results in breathing difficulties that might take months to improve. Remember all those fibrotic changes with ARDS? So as COVID-19 viral pneumonia progresses, more of the air sacs become filled with fluid, leaking from the tiny blood vessels in the lungs. And then, of course, eventually we get the shortness of breath that sets in, and then this all leads to ARDS. So many clinicians are saying that ARDS is different with patients who have COVID. So patients have low oxygen saturations without an increased work of breathing. That is not usual with ARDS. So with ARDS, when patients are hypoxic, you see them. They are working really hard to breathe, and it's very clear that they will not be able to sustain their work of breathing and will need to be on a ventilator. So that was something different with COVID, that they'll have low oxygen saturations, but they don't look like they're having trouble breathing. So critical care and pulmonary specialists have agreed that clotting also is prevalent in COVID-19 patients. So you might get PEs, other clots. The vast majority have elevated D-dimers, though it's unclear if the D-dimer is a true marker of thrombosis in such an inflammatory setting. They're also noticing overt pulmonary embolism, or the microemboli that are developing in the lungs. So there's a plausible argument that maybe this is related to a procoagulant state with COVID patients. In a recent study, it reported that as many as 85% of ICU patients with COVID-19 meet the definition of ARDS. So you can almost guarantee that your patients at some point with COVID-19, if they do not get better and they're progressing, it's going to develop into ARDS. Treatment includes already whatever we have well established for supportive interventions for ARDS. So we'll do low tidal volumes. We'll do prone ventilation, which results in significant improvement in oxygenation and lung compliance. So prone positioning, they're laying on their belly. They will be ventilated. It optimizes lung perfusion and lung recruitment. It reduces a barotrauma risk, and we'll go into what barotrauma risk is. It enhances secretion clearance, and it may alleviate the right ventricular strain that occurs secondary to the increased pulmonary vascular resistance that occurs during hypoxemia and hypercarbia. So that's why we do prone positioning. In some patients, if ventilator treatment fails with COVID or ARDS, patients really to help adequately improve their blood oxygen levels, or if we're finding they're unsuited to really be mechanically ventilated, doctors will place ARDS patients on an ECMO, or it's extracorporeal membrane oxygenation, so ECMO therapy. So in ECMO therapy, a machine takes over the functions usually performed by the lungs, and if necessary, the heart too. This machine uses a pump to circulate blood through an artificial lung outside of the body, where oxygenation and CO2 removal takes place. Blood is returned into the bloodstream. This is a very invasive therapy and is used as a later option for treatment. And it's good to know that people who survive ARDS in general and those who recover from COVID-19 may have lasting pulmonary scarring. Some treatment. So treatments for COVID-19, we've talked or at least heard about antiviral drugs. Remdesivir is one that is given, but it's really only given to those who are very sick and who are hospitalized. There's also monoclonal antibodies that are lab-made molecules. They act as a substitute antibodies, so they can help the immune system recognize and respond more effectively to the virus, making it more difficult for the virus to reproduce and cause harm. It's really only given to those who are at high risk for this progression of patients into severe COVID-19 and into severe ARDS. We do corticosteroids. Remember what steroids do. There's inhaled vasodilators that we'll also do. Sometimes we'll even do surfactant therapy, which are agents that accelerate the lung water resolution and ion transport. So they do surfactant therapy with a nebulizer treatment. There's also, of course, our anti-infective, antibiotics, antivirals that we also do. So just some good information about what you'll see in your patients with COVID. All right, so let's do a connection check question. So pulmonary edema associated with ARDS is caused by increased permeability of the alveolar capillary membrane, right ventricular failure with pulmonary hypertension, left ventricular failure due to poor oxygenation, or fluid overload related to resuscitation in the first phase. Go ahead and answer. Pause. And then you can restart when you've answered your question. So the answer is A, rationale. So we have pulmonary edema that's non-cardiogenic. So it's caused by that leak of the plasma out of the vascular space into the alveoli and interstitial spaces. You have damaged capillary membranes that allow plasma and blood cells to escape into interstitial spaces. So continuing on with our case study patient. So after stabilization of JT's injuries, he's admitted to ICU. The bleeding into the thoracic cavity has stopped, but the lung has not fully expanded. On the second day in the unit, his pulse oximetry continues to decline in spite of increased FiO2 via 100% non-rebreather. He is tachypnic and tachycardic. A chest x-ray shows diffuse infiltrates bilaterally. Remember, we see that on our ARDS patients. An ABG shows the following. So pH 7.5, PaCO2 of 32, PaO2 of 50, HCO3 or bicarb 28, while 70% of FiO2. It's determined that JT has developed ARDS, of course. JT is intubated and mechanical ventilation is initiated. So why does this patient require mechanical ventilation? And what are the signs and symptoms he has that are consistent with ARDS? So again, pause, answer the questions, and then when you're ready to hear the answers, click play again, and you will get your answer. So the answers for case study. We've got our ABGs that are showing respiratory alkalosis, and mechanical ventilation is the primary treatment for his refractory hypoxemia with ARDS. It's initiated as lung compliance decreases, work of breathing increases, and oxygenation continues to be refractory regardless of interventions. So we'll try all the non-invasive positive pressure ventilation, BiPAP, and all the other oxygen therapies available before we would do ventilation or mechanical ventilation. So remember the ARDS, the three phases, we have exudative, proliferative, and fibrotic. So because of release of inflammatory mediators, there's this disruption of the alveolar capillary membrane. Alveolar and interstitial edema also occurs, and there's damage to the alveolar cells that produce surfactant. Surfactant's responsible for maintaining that alveolar surface tension. It keeps the alveoli from fully collapsing at the end of expiration. If this is lost, the alveoli collapse, and that's also called atelectasis. Signs and symptoms of ARDS with this patient, we've got tachypnea, tachycardia, and this is as a compensatory response to the hypoxemia. Remember, we have respiratory alkalosis, and that's present. Chest x-ray reveals bilateral infiltrates, referred as pulmonary edema. And these are all clinical manifestations in the exudative phase. So for diagnostics, we're going to do, of course, some x-rays, plenty of chest x-rays while they're there. So in the x-ray, it may or may not be evident in the first 24 hours of onset. So you'll see these bilateral diffuse infiltrates, which are the hallmark sign of this disease process. Sometimes it's described as a whiteout or snow screen pattern or a ground glass appearance. Chest x-rays reveal the increased alveolar fluid as these bilateral infiltrates, and it's referred to as pulmonary edema. Chest CT, of course, would show the alveolar consolidation and atelectasis, so just be a little bit more specific with the imaging. And then we could do pulmonary function tests that would show us the lung compliance, that it has decreased vital capacity, and that its functional vital capacity have also decreased. So you see the snow screen on the image here, the image to the right. So for diagnostics, of course, we're going to be doing some ABGs. Remember, initially it'll show hypoxemia. Your PaO2 will be less than 60, and respiratory alkalosis. So the pH will be greater than 7.45, and we'll have hypocapnia with the PaCO2 less than 35. CBC, it'll help to determine if the cause is from infection, so we want to look at the white blood cell count. We'll do sputum, urine, and blood cultures, determine the source of infection. And then we'll do a CMP, which is our comprehensive metabolic panel. We're going to look at electrolytes, renal, liver, and coagulation studies, and try to look for any other symptom or systems that are affected, and potentially any complications that are forming from ARDS. Management. So we'll start with our 100% non-rebreather for the hypoxemia. If refractory and if there's a rise in PaCO2, then ventilatory support for our acute respiratory failure is the next step. So you may also use the non-invasive positive pressure ventilation, CPAP or BiPAP. I'd say we usually do BiPAP, depending on how the patient, we try all of these non-invasive oxygenation apparatuses before we decide to do mechanical ventilation, unless if they're just really struggling to begin with. So CPAP or BiPAP, we talked a little bit about this earlier. So remember, CPAP maintains one continuous pressure throughout the respiratory cycle to help keep the alveoli open through inspiration and expiration. And then BiPAP, bi mean two different pressures. So you have a higher pressure during inhalations, and it assists with the opening of the alveoli and lowers pressures during exhalation. It keeps the alveoli from collapsing during the end of exhalation. BiPAP really is sort of a mechanism that helps those patients who are really struggling to breathe, that are super tachypnic, it does the breathing for them without being super invasive. So mechanical ventilation, it is sort of the primary treatment for the refractory hypoxemia that occurs with our ARDS patients. So we'll intubate and ventilate patients as that lung compliance decreases, as they're working harder and harder to breathe, and their oxygenation continues to be refractory regardless of the interventions we're doing, then we will go ahead and intubate and do mechanical ventilation. So rationale for it, it's initiated as lung compliance decreases, work of breathing is increased, oxygenation continues to be refractory, even though we've tried CPAP, BiPAP, all other oxygen therapies. So our goal for mechanical ventilation is we want an FiO2 titrated to the lowest rate to maintain a PaO2 greater than 60. And oxygen saturation, of course, we want greater than 90%. And then we also want to keep the patient's acid-base balance with the normal range. So remember, pH is 7.35 to 7.45, CO2 at 35 to 45, and then our O2 80 to 100. And that's with our ABGs. So goal for mechanical ventilation is to keep the FiO2 less than or equal to 50% to avoid toxicity. All right. Now, with ARDS too, we want to use lower tidal volumes. So we want to prevent any ventilator-induced lung injuries. And yes, we can cause injuries with mechanical ventilation. So one injury that can be caused is barotrauma, which means alveolar rupture. So inflammatory cells infiltrate, you have this increased vascular permeability, and lower tidal volumes are needed due to the decrease in lung compliance. Tidal volumes are the volume of air moved with one breath, one inhalation and one exhalation. So tidal volumes, air moved with one breath, one inhalation and exhalation. So it's that volume of air. Increased PEEP. So PEEP, what is that? It's positive end expiratory pressure. PEEP is needed with mechanical ventilation to help keep the alveoli open and promote better gas exchange. So we will increase the PEEP with the use of lower tidal volumes. So some of the adverse effects of too much PEEP include increased pressure in the chest, which would then decrease cardiac output and increase the risk of barotrauma, such as pneumothorax. Just try to remember that PEEP is like your pressure, amount of pressure in your lungs. There are other ventilatory modes sometimes used in the treatment of ARDS. So, and we'll go into this in a little bit because we want to talk about different modes of ventilation. It depends. It just depends on what would be best for that patient. We do tend to titrate it and use what is best based on what symptoms they're having and how their lungs and oxygen are responding. So we might try even high flow nasal cannula too. We're talking about another mode of oxygenation besides mechanical ventilation. So we did talk about BiPAP and CPAP, but I did forget to mention high flow nasal cannula, which seems to be used more often too. So this can be used during the early phase of ARDS as a form of non-invasive ventilation. So the oxygen's humidified and warmed, and it's delivered through soft, wide-bore nasal prongs. Looks like they've got a scuba tubing coming out of their nose. The high flow rate optimizes alveolar ventilation and also increases nasopharyngeal airway pressure. It produces actually a CPAP effect. So this will improve oxygenation and decrease the work of breathing. So sometimes if we have patients who are having difficulties with like a traditional CPAP mask, we can try high flow oxygenation because it acts similarly to the effects of what the CPAP machine does. And let's go into the next slide because we do want to talk a little bit about modes of ventilation. So, all right, so there are many ways we can put air into our patients. So try to remember, that's what we're doing with mechanical ventilation. We're putting air into our patients. We can inflate them to a certain pressure. We can make their respiratory rate fast. We can make a respiratory rate slow. We can also adjust the flow rate so we can have the volume of air going into their lungs slow or quick. And we can provide lots of oxygen or a little bit of oxygen. So we can also even be in charge of when they receive a breath, either by us or the patient. So each one of these types of things with oxygenation and how we put air into our patients is a different mode of ventilation. All right. So, let me go back. So, AC, assist control. All breaths are delivered at a specific set tidal volume. With each ventilated breath, there's a guaranteed volume of 500, with each ventilated breath typically used with unstable patients who need full ventilatory support. So the ventilator will only initiate breaths if the patient initiated rate falls below the set rate of the machine. And then there's continuous mandatory ventilation. This is the most common mode. The patient essentially triggers the vent with our AC, with assist control. Patient takes a breath in, negative pressure is sensed at the ventilator or through flow that goes to the negative pressure. As soon as the ventilator picks up on the negative pressure, it'll deliver a specific volume. So volumes that are provided range from 500 to 600 cc's. The rate can also be set for 12 breaths a minute, whatever we want it to be at. And then we can also tell it to deliver a breath every so many seconds, every 5 seconds is typical. Only if the patient doesn't deliver it itself. And the patient with this mode, so the patient will never receive less than 12 breaths a minute. Taking enough breaths, pushing air and oxygen into respiratory tracts. So this is one thing to remember with assist control is that it's the most common ventilator mode to use, especially in newly intubated patients. So it's really a mode that provides good comfort. It's easy control of really the most important physiological parameters for these patients. Pressure control, so that delivers a predetermined pressure to help inflate lungs. It might not guarantee a good tidal volume amount, but the patient will receive the pressure needed to make sure that they're ventilated. So it's pressure. ARDS, you do not want to overinflate lungs since they're already constricted. You want to avoid damage. So pressure readings for lung compliance are based on the volume delivered into the lung. We set the tidal volume on the ventilator, and that will tell you what the pressure is. So you're setting how much volume of gas goes into the lungs. So based on how compliant the lung is, it'll tell us what that pressure is. If the compliance of the lung is down, you'll have higher pressures. If the patient has high lung compliance, then your pressures will be lower. SIMV, or synchronized intermittent mandatory ventilation, this is our weaning mode. Important to know that SIMV is our weaning mode. We're getting them off of the ventilator. So in this mode, there's no ventilator assistance between the set respiratory rate. So patients will pull their own volume on the breath outside that set limit. The patient is in control of the respirations and taking control of the ventilator. The vent delivers some settings. It tries to deliver the same setting. So the rate of 12 breaths per minute and a tidal volume of 500. But if the patient breathes on their own, the vent will assist with breathing. So really, this mode helps the patient during the weaning process. We'll see pressure support ventilation along with SIMV for weaning. So this sort of lets us know, is the patient able to pull their own volume on the breaths outside the set limit? This lets us know, can they essentially breathe on their own without having to remove the ventilator? So for weaning patients off the ventilator, nurses will complete weaning trials, and this you might see when you're in SICU. So we're the ones that help, along with respiratory therapy, to do these weaning trials. Now in the hospital, the respiratory therapists are the ones that are officially in control of the ventilator settings. They'll change what they need to change. They have to constantly assess these patients. But it's good for the nurses to know, and we need to know what settings they're on. We need to know when it alarms, what to do, what it's telling us when it's alarming. So that's why we're giving this information. You're not going to be critical care nurses right off the bat. Some of you may or may not be. But this is good information for you to know, especially for those of you who are wanting to go into critical care. And for when you go into SICU, you can kind of get an understanding of what the ventilator is doing for that patient. So what we do for weaning trials as nurses, we try to do a spontaneous awakening trial. So this is where we wean them off of sedation a little bit to check neurological status. So an example of where we would use this, especially, is with our alcohol withdrawal patients. Most of the time we want them sedated because they might be just thrashing about everywhere. So we'll wean them off of their sedation to the point where we can do a good neurological assessment. We can also do this with spontaneous breathing trials, because a lot of times when they're on a vent, they're also on sedation. So we will wean them off of their sedation and then start the spontaneous breathing trial with the SIMV type of weaning mode on the ventilator. We want to see if the patient's able to breathe on their own. This is usually ordered by the physician and is facility dependent based on standard protocols or policies. We would usually do this once per shift, so once every 12 hours. 12 to 24, depending on the severity of the patient. Another type of ventilator is PSV, or pressure support ventilation. This really gives us a defined amount of pressure with patient-initiated breath. So there's really no ventilator-initiated breath with this. The patient is spontaneously breathing, but the ventilator augments the patient's respiratory effort with a pressure support. Well, that's why it says pressure support ventilation. So in pressure control, we're deciding how much pressure to put into the lung. Compliance is equal to the change in volume over the change in pressure. The patient or time can be set to trigger a set change in pressure. So really, a lot of it will depend on the compliance of the lung and how much volume the lung can take. So definitely alarms need to be set. We need to have good parameters set with this type of pressure support ventilation. We want to know if the lung compliance drops suddenly, because the volume will drop, and we want to know that. It essentially overcomes the work of breathing. So if the patient's not ready to be weaned or not breathing on their own, they really shouldn't be in this mode. So they really need assist control mode. So remember, assist control is our most common mode of ventilation. So we would not be using pressure support ventilation for weaning or for patients that are super sedated. Okay, another method is bi-level or bi-mode. So you might see this when a conventional ventilator is not working for a patient. Not all ventilators have this setting. There's high and low settings. It gives longer inspiration and shorter expiration. Bi-level mode helps with patients who have oxygenation problems or regular vent is not working. Mainly when it comes to modes of ventilation, I want you to just know what the most common mode of ventilation is for ARDS patients, and what are some of the signs and symptoms to watch out for with lung injuries that we can cause. Here's a picture of a ventilator monitor. So we do want you to know a few of these settings. It's important because you will be tested on some of this. So ventilator settings, they are ordered by the physician. Usually we'll have respiratory therapy maybe recommend some changes, but it has to be ordered by the physician. There's a pocket ventilator guide too that I put up on Canvas that you can review. It's really just for your information. Um, I'm really only reviewing the vent settings that are pertinent to nursing and what we would assess in the critical care setting. So P, the big P, little p for peak, peak, which is peak inspiratory pressure. It reflects the total inspiratory work by the vent and reflects resistance and lung compliance. So another way to look at this setting is to view as the lung compliance pressure or the amount of pressure to push air in. We want to watch for increasing pressures. This patient may need suctioning or sedation. So if you have higher pressure and high pressure alarms, that means that there's decreased lung compliance. The IE is inspiration expiration. So the IE ratio is the ratio of the duration of inspiration and expiratory phases. It represents a compromise between ventilation and oxygenation. So a normal IE ratio is 1 to 2. If you want more inspiratory time, then your IE is 1 to 1.5 or 1 to 1. That will increase the mean airway pressure. It favors better oxygenation at the cost of CO2 clearance, though. If you want more expiratory time, then you might see an IE ratio of 1 to 2.5 to 4 and higher. So this increases the expiratory CO2 clearance and favors better ventilation in that aspect. So it'll vary with the type of disease process, your IE ratio. If it's COPD, they might have a very short inspiration with a very long expiration. The goal, it really is to simulate sort of a normal breathing pattern. 1 to 2 is normal, a normal IE ratio. So RR is the true total respiratory rate. So RR is also F, RR or F. So if the vent shows 16 in AC below and this shows 20, patient is taking 4 breaths. So this can be found in the top right of the vent screen. So if you see VTE up there, I'm trying to see where it's at. Oh, sorry, I'm looking at the wrong one. Okay, so RR is the true total respiratory rate, RR or F. Let's see. So up here, the true respiratory rate on this image is the one that's that kind of little F, and then it's TOT. So FTOT, that's their respiratory rate is 24. Okay, next is VTE, which is right next to the other setting. So VTE is their end tidal volume. This is the volume of air exhaled with each breath. So we want the volume going in to roughly equal the volume being exhaled. So if we have issues with their end tidal volume or their VTE, we're going to need to troubleshoot, and we can usually identify an air leak if the VTE is really low. And then our modes. So you can see this is AC mode. Again, we talked about different types of ventilatory modes. There's tidal volume or TV. Please know what TV tidal volume is. It controls the amount of gas delivered with each breath or the amount of air required to inflate the lung. Normal tidal volume is about 500 to 750 mLs for vent settings. Based on the patient size and weight too, so a typical calculation used, and this is something that physicians and respiratory therapists would do, is so tidal volume measurement is 6 to 8 milliliters a kilogram. So if a patient weighs 75 kilograms, they'll be set to receive 450 mLs tidal volume. This is it. If it's set too high, we don't want a high volume set, we can overinflate the patient. FiO2 is our fractional inspiration of oxygen. So typically it's set between 40 to 100%. It's the amount of oxygen the patient is given, found in the bottom right corner of the vent screen. recall room air is 21% oxygen. So the air that we're breathing in right now is 21% oxygen. The vent, the minimum for the vent is 28 to 30% oxygen. So we also need to make sure that we heat and humidify the air that's delivered from the ventilator. Dry, cold air can damage the delicate tissues of the airways and cause mucus plugs. So in this case, if you look down in the bottom right-hand corner of the screen, it says O2, it doesn't say FiO2, but O2 at 45%, that's their FiO2. And for reference, so look at this monitor screen and anything, like draw an imaginary line in the middle of the screen. So whatever numbers you see at the top are what the patient's doing. Whatever's below, so all those settings in the bottom, are what the vent is set at. So top is what the patient's doing, bottom is what the ventilator settings are. PEEP, we talked a little bit about this, positive end expiration pressure. This is the amount of air in the lung at the end of expiration. So 5 centimeters is natural pressure. So PEEP of 5, that's 5 centimeters is regular pressure. That's the normal pressure needed for the patient, since the glottis is not closed when on a vent. So we must keep the lungs pressurized to avoid lung collapse. PEEP keeps the alveoli open after expiration, keeps them from collapsing, allowing maximum gas exchange to continue throughout the respiratory cycle. So this patient's PEEP is at a setting of 5, looking at the monitor. Okay. Vent alarms. So vent alarms should always be on. I mean, I know that alarm fatigue exists. Make sure you look at the patient first when the vent's alarming. If you cannot be sure the vent's functioning properly, remove the patient from the vent and then just start ambu bagging them at the patient with the patient at 100% oxygen. Make sure that you follow your ABCs, airway and breathing, and then also contact respiratory therapy to come check out the vent. Many times they are able to really troubleshoot for us. They're a good resource. Okay. And really, like we were talking about this a little bit, I think, with another student, is that when you have somebody who's mechanically ventilated and we're doing CPR, the breath ratio will be different. And a lot of times we will disconnect them from the vent so that we are the ones providing the ventilation to the patient, and we'll just really, it's easy to remove it. You just unhook the vent piece from the ET tube and then place an ambu bag right on top, and that's it, and then we ventilate them ourselves. This is a picture that I took at the hospital last term of what it looks like in SICU. So these are the current ventilators that they use. It looks a little bit different, but you can look at their settings again on the bottom. Those are the settings, and then at the top is what the patient's doing. Okay. So we do want you to be aware of what ventilator alarms there could be, and you should know this too. So high pressure alarms, it could be that they're biting, there's a blockage that's present. So remember peak airway pressure. If that's elevated or becoming elevated, or if the number is high, there's increased pressure that's inflating the lungs. So try suctioning. There might also be decreased lung compliance. The lungs are becoming stiffer. So you want to keep an eye on this, especially with our ARDS patients. So high pressure alarms will sound when the pressure in the circuit has increased. It helps protect the lungs from getting too high a pressure delivered on the ventilator. We can get secretions. There can be water even in the tubing or kinks in the tubing that can cause high pressure. You want to make sure that you suction the patient and look for other sources. If this does not fix the problem, you always can disconnect them from the circuit and then manually ventilate them with an ambu bag. Then call for help. Low pressure alarms, know this as well. It's usually a system issue or air leak. So it indicates that the pressure in the ventilator circuit has stopped. dropped. So low pressure alarms are usually caused by a leak or disconnect. Usually the patient somehow, if they're not sedated enough, will disconnect the tube there. Hopefully they have not self-extubated. So this can also include a leak at the site where the tracheostomy tube enters the neck, and that can happen. If they're struggling for air, just disconnect the circuit again from the patient and manually ventilate with an ambu bag. So that's kind of the guaranteed way that you know that you're still providing oxygenation to your patients if you're having troubles with, if it's a severe issue with the ventilator not functioning correctly, then you can just remove the tubing from the vent and then do the ambu bag and self-ventilate. Here are some ventilator breathing patterns that may cause monitor alarms. If you look on the images from the monitor screens of the ventilators, you can see their respiratory pattern. So we'll talk more about this with our intracranial regulations lecture, but it's just interesting information for you at this point to know what those hills and sometimes, with respiratory rate, even with our with it like a CO2 monitor, when we're monitoring their CO2, it can tell us their respiratory rate and the patterns, how they're breathing. So positioning, this can be adjunctive therapy in ARDS. So this is what it looks like for proning. We talked about this before, but you increase oxygen to the posterior alveoli that have collapsed. Posterior is nearly all lower lobes. So that the posterior alveoli that have collapsed are posterior are all lower lobes. It aids in secretion, extravascular water distribution. It decreases stress on the soft tissues of the lungs. It helps to improve lung capacity by opening more alveoli, which of course will improve oxygenation. It reduces the need for higher PEEP and FiO2, decreasing ventilator-induced lung injuries. And then blood flow is also increased to better aerate in the anterior portion of the lungs. We'll usually implement this within 72 hours of diagnosis. We can do this up to 20 hours per day, and that's recommended for the best results. It can be accomplished by manually turning the patient in the bed or using a mechanical device that can help turn the patient. There are some contraindications with this, so any spine instability or injuries, any patients at risk for increased intracranial pressure if they're pregnant, any abdominal wounds, any unstable fractures, or if they're a patient who needs to have frequent access to the airway. So what are some considerations with proning positioning? You need to really monitor them for any changes in baseline oxygenation parameters, especially right after proning. And then you should alert you to collect a new ABG result. They might want to do that anyways as soon as you start proning to see if it's helping, to see if proning has helped this patient. Eye and facial skincare must be assessed. So you might want to use an eye lubricant and padding of the areas of the face. Definitely use some good sedation. Enteral feeding should be stopped at least 1 hour before proning, and parenteral feeding may need to be considered for longer durations of prone positioning. So they might decide to do TPN and lipids instead. And then have a plan in place for a rapid return to the supine position in case of hemodynamic compromise or cardiac arrest. All right, so what are some drugs that we going to use for ARDS? So antibiotics, of course, if the cause of ARDS is from an infection. We want to watch for nephrotoxicity, so we're going to do some drug level monitoring. For those of you who have given vancomycin in clinical, you know that we're trying to see is there a vancomycin trough, which they will draw before you give a dose, and that tells us whether or not they're at a therapeutic drug level for that antibiotic. There's corticosteroids, which is methylprednisolone. That decreases inflammation, but it can also have some very negative side effects. So the use can also affect the body's inflammatory response, making the patient more susceptible to secondary infections. We're kind of doing more research on that. So it's ongoing research with steroid use. And then neuromuscular blockers or paralytics. So a lot of times we'll use two different drugs. They're common. So it's succinylcholine or rocuronium. You might hear them say rock or sucks for succinylcholine. These are in the rapid intubation kits. So they're in the Pyxis. So if we ever have a situation where we need to do rapid sedation for a patient, then we will grab our RSI kit out of the Pyxis, which has all of these agents in there in vials that we can draw up. It'll have whatever else we need to for sedation. So we want to use neuromuscular blockers or paralytics with our ventilated patients, because it really, especially when we're intubating them to begin with, we'll always use a neuromuscular blocking agent because it keeps the patient from moving at all while we're trying to intubate them. So typically you won't see it used after the point of intubation, but sometimes it is used in patients who are mechanically ventilated, especially those who have severe ARDS, because we want everything to work. We want our ventilator to do the work for the patient. It's non-sedating, so these are non-sedating drugs. It's just that they're paralytic, so they essentially just make the patient unable to move. Succinylcholine is the most well-known depolarizing neuromuscular blocking agent. It's considered to be the drug of choice for emergency department RSI kits. So that's rapid sequence intubation. It provides the optimal conditions during intubation of critically ill patients. So also these drugs help to reduce oxygen demand by limiting that muscle movement, so they're paralyzed. It can keep the breathing keeps the breaths in sync with the ventilator. It helps to reduce that barotrauma risk. But just remember that these patients will also need sedative drugs and pain relief medications too, depending on what they're there for optimum comfort. So I can imagine having this being paralyzed and then not being sedated. We also use Precedex or midazolam. They're common for sedative drugs, and propofol. So when you go into SICU for your rotation, try to pay attention to those patients, or if you don't have a patient, that you should, but if a patient you have that day with the nurse is not intubated, go in, see what sort of sedation drugs they're on, ask questions, check their ventilator, check the settings. Another thing with mechanical ventilation is that they almost always will need that sedation. So for sedation, what do we do to monitor these patients? You might see the nurses use what's called a RAS scale. It's the Richmond Agitation and Sedation Scale. So it's a 10-point scale. So it has 4 levels of anxiety or agitation. So it's a +4 or there's 5 levels of sedation, excuse me. So on one extreme of the RAS score, you have +4. A +4 represents a very combative, violent patient who's considered dangerous to the staff. And a -5 is somebody who's unarousable. So, or a +5 is somebody who's completely, we don't want a combative patient on a ventilator. So a lot of times what physicians will do, and you can ask the nurses in SICU, is what do they use to monitor sedation scale? So what are we doing to know that our patient is not over sedated or under sedated? So this is what the RAS scoring is used for. They might say, a doctor's order will say, keep RAS score between -2 and +1. So just good information for you to know that nurses do monitor the amount of sedation that we give, and this is the scale that we use. Hydration and nutrition. So, it's kind of put on the back burner, but it is important with these ARDS patients. So With decreased cardiac output and thick secretions, they need some fluid. They really do need fluid. So they need adequate hydration, especially our vented patients. So it's necessary to maintain that circulatory volume, and it also avoids these issues that we can get with really thick, dry secretions. And those can be super difficult to clear and then potentially cause plugged airways. So it's really with the hydration piece of it, we want to be delicate with the balance. Remember, we have that increased permeability of the alveoli, and we don't want too much fluid. So we don't want to worsen the ARDS, but we know they need it. They need it for hemodynamic monitoring. We want to monitor the urine output and volume status. We need to have a central venous catheter or pulmonary artery catheter, and we need an arterial line. We're drawing multiple AVGs on these patients. Another thing with ARDS is it's associated with a hypermetabolic and pro-inflammatory state. So patients need nutrition. They're at risk for malnutrition. They are using the loss of body mass that can occur because of the nutritional needs is something that can be overlooked, but we need to take care of this. So they are at risk for malnutrition and the loss of body mass. So they also can have reduced respiratory muscle strength. So be aware of these. And then they'll usually have enteral nasogastric or orogastric tubes. We would do tube feedings through those, the NG or OG. But just remember there's a risk of aspiration. If we're not proning them, then we'll probably do tube feedings too. But if they're prone position, we might use TPN, something different. There's the risk of aspiration, so make sure you have that head of the bed up to 30 degrees. Check our residuals. Parenteral nutrition, which is the IV nutrition, TPN or lipids. It's given through a central venous catheter. Just remember that they're at a higher risk of CLABSI, which is the central line-associated bloodstream infection. There's also an evidence-based article on CLABSI, and the link is provided to you right in the slide. It's just some good information about what CLABSI is. All right, so ventilator complications. We've talked a little bit about these. So barotrauma, pneumothorax. What are some signs and symptoms? You might have that pneumomediastinum where the air is in the mediastinal space, or pneumothorax where there's air in the pleural space. It can cause further hypoxemia. In regards to mechanical ventilation, the tidal volume should be kept as low as possible to prevent volutrauma and barotrauma in these patients especially. So remember careful application of tidal volume and PEEP to maximize oxygenation without causing barotrauma. And that's sort of the golden rule for everyone on a ventilator. You can also get ventilator-associated pneumonia or VAP. Evidence-based practice, chapter 27, page 530. So please read that article. It's difficult to detect. You might get development of a fever, leukocytosis. You might have an increased respiratory effort. Purulent secretions are a hallmark sign of VAP. And then we'll need to do sputum cultures to confirm there's an infection. So what interventions do? We do mouth care every 2 hours. We'll use either a piece that attaches to the suction that's kind of like a toothbrush or a foam toothette that we put chlorhexidine on, and then do good mouth care with that at least every 12 hours. And then we'll keep the head of the bed elevated at all times to 30 degrees to prevent that gastric aspiration. There's also some cardiovascular or this multi-system organ dysfunction syndrome that occur. We also call that MODS. So increased pressure in the chest decreases venous return and ventricular filling. It decreases the cardiac output. It can cause hypoperfusion of the liver and kidneys due to shock. It results from prolonged refractory hypoxemia, hemodynamic instability, and the inflammation associated with sepsis. We want to monitor labs really closely. Watch our hemodynamics. Signs and symptoms for GI ventilator complications. You don't think about gastrointestinal complications, but they can occur. We can get stress ulcers. They can also have lots of constipation, and they can have gastric distension. So it's super important that, and again, it's another thing that kind of can get on the back burner. We don't think about bowel movements in the ICU, but it can happen. So they're usually on regular uh, stool softeners, laxatives. We usually put them on protonics or PPI to prevent stress ulcers. Make sure you remember that. And, we want to keep a close eye on monitoring their bowel movements. So let's do a question here, connection check. The nurse understands the priority action for a patient with a chest tube that has come disconnected from the chest drainage system is which of the following? All right. A, immediately cover the end of the chest tube with a sterile dressing. B, immediately submerge the end of the chest tube in sterile water. C, immediately reconnect the end of the chest tube with the drainage system. D, immediately page the provider to insert a new chest tube. Go ahead and answer. Pause if you need to. Okay, the answer is B. So if a chest tube becomes disconnected from the drainage system, it is imperative to submerge it into about 1 to 2 inches of sterile water to provide a water seal until a new drainage system is connected. And then, of course, we will contact the physician. Okay, so subglottic secretion drainage. So this is if the patient has a conventional ET tube, it needs to be replaced with an ET tube that has a subglottic secretion drainage. These seem very common now. The new ones that have this subglottic secretion drainage system. So they have an extra port above the inflated cup that's connected to continuous suctioning, and really what that does is it prevents secretions from pooling and developing around that cup area, and it keeps it from developing a ventilator-associated pneumonia or VAP. So it prevents it from becoming infected with bacteria and then oozing down around the cup into the airway, infecting the airway. So they'll want to change it out as soon as possible. Okay. Ventilator weaning, we talked a little bit about this. So it depends on a few factors. The earlier, the better. We do not want our patients long-term on ventilators. Weaning trials are completed at a minimum once per day, typically once per shift. Depends on the physician, especially if they're really close to be weaned off, if they sort of barely failed one of the weaning trials. We'll want to monitor vital signs. We'll do ABGs, and they might even draw an ABG during the vent trial, the ventilator weaning trial. And then dyspnea those are all used to evaluate, is it working? So vital signs, ABG, dyspnea, those are really the 3 things we'll look at to evaluate if they're ready to be weaned off the ventilator. I told you about the sedation or a spontaneous breathing trial, and we'll do a sedation vacation or a drug holiday. So, we'll wean them off of the sedation to the point that they're awake enough to do the breathing on their own. And we'll see how they do. We'll try to give them minimal or no ventilator support. And the most common weaning trial we utilized in ICU is the continuous positive airway pressure. So you can also do that with the ventilator. So the SIMV and PSV are the ones that are used for weaning. So using a CPAP level is equal to the previous positive end expiratory pressure level. And then just remember that the 2 types of ventilator modes used for weaning patients off the vent is that SIM, the SIMV, synchronized intermittent mandatory ventilation, and PSV, which is pressure support ventilation, because in these 2 cases, the patient's initiating the breaths. And then with the synchronized intermittent mandatory ventilation, there's no ventilator assistance between the set rate. So the patient will pull their own volume on breaths outside the set limit. PSV is our pressure support ventilation. It gives defined amounts of pressure with patient-initiated breaths, no ventilator-initiated breath. Please remember what PSV is for. So PSV gives a defined amount of pressure with patient-initiated breaths. And then if there's terminal weaning or extubation, make sure that they're very well medicated. Lots of Ativan. I remember we did one terminal weaning on a patient who was still awake and alert, but he had been on the vent forever, and the family wanted it out, and he wanted it out. So we did, and it was awful to watch him because obviously after we removed the airway, and this was when I was orienting as an ICU nurse too, so this, wasn't a great experience. It's one I remember. And the nurse I was working with didn't sedate him enough and didn't give him enough Ativan, so he was blue, cyanotic, struggling. I mean, it was awful watching him struggle to breathe. I mean, he eventually passed, but it seemed like forever, but it was probably only a few minutes. So definitely, if you're ever having to witness or be there with terminal weaning or extubation, or you're taking care of a patient in this instance, make sure you give them enough Ativan or sedation. Make sure they're well medicated. So, questions. Let's do some review. So an early sign of hypoxemia is clubbing of the fingernails, cyanosis, somnolence, or restlessness and anxiety. It's D. So you have someone who is experiencing hypoxemia. They'll show restlessness and anxiety first due to those decreased oxygen levels and oxygen flow to the brain, right? Cyanosis occurs later. Clubbing is a sign of long-term hypoxemia, and then somnolence may indicate increased PaCO2. So they're acidotic. Nursing management of these patients. So we want to do lots of good assessments on them. Lung sounds, especially. Make sure you know what abnormals to look for. What are we watching out for? Crackles may be auscultated because of fluid buildup in the alveoli. Remember that increased capillary permeability. Later on, it may be diminished because of atelectasis and fibrotic changes in the lungs. Our SpO2, pulse oximetry reading is low because of the VQ mismatch and intrapulmonary shunting. Vital signs, the pulse increases due to the hypoxemia. It is a compensatory mechanism. The respiratory rate increases in an attempt to increase oxygenation. Blood pressure may be decreased because of right heart failure and the increased intrathoracic pressure. Thus, decreased venous return associated with PEEP. Definitely do lots of hemodynamic monitoring. They'll have a CVP or PA pressures. Those might be decreased because of the decreased venous return. You really want to monitor that. Labs, ABGs, lactate, CBC, culture, CMP. Do good skin assessment. These patients are definitely at an increased risk for skin breakdown due to them being immobile and sedated. Watch the urine output. Remember, we want a good balance. We want to make sure that they're at least 30 cc's an hour. And then 2, decreased urine output is an early sign of poor oxygen delivery to the tissues and shock. And then chest x-rays, they'll at least do daily chest x-rays to monitor the progression or improvement of ARDS. Another thing for nursing management, we want to make sure that we're aware of the ventilator alarms. We're going to do frequent monitoring of airway pressures. Remember that airway pressures can indicate the presence of secretions or worsening lung compliance. A decrease in airway pressure may indicate a leak in the system, and we'll do EKGs. We'll want to look for any dysrhythmias that might be caused by the hypoxemia. Some actions we're definitely going to do a lot of suctioning, ET tube care, maintain our medications. We'll have our sedative drugs. If they need it, our vasoactive, zynotrope, antibiotic, corticosteroids, lots of positioning. And then we talked mostly about those skin interventions. Head of bed needs to be up. Range of motion is good too. And then our infection prevention. So ventilator-associated pneumonia prevention, CLABSI, Foley's, all that. So for patient teaching, we want to make sure that, of course, if they're sedated, this won't apply as much, but family members, if they're available, we want to teach them about the disease process of ARDS, the pathophysiology and medications, what the lines are, ventilator, family engagement, whatever the visiting hours are, unit routines. And just remember, even though they're sedated, they can still hear. And I know with my patients, when they were sedated, I would still talk to them just like they were awake. I would tell them everything I'm doing, exactly what I'm doing. I'm going to lift up your arm. I'm going to touch you here, because they can hear and they will remember. So evaluating outcomes, there is a high mortality rate with ARDS. It's near 50%. But we do have many ways to treat ARDS. There's a lot of pulmonary complications that we need to look out for. Of course, we want them to return to baseline. And then it can be physically debilitating. We want to see they most likely will need to be in rehab and need some counseling afterwards. Okay, case study wrap up. JT remains in the ICU sedated on the ventilator. He is managed with conventional mechanical ventilation with low tidal volumes to protect his lungs from injury. His fluid balance is managed judiciously. He started on enteral feeding to support his nutrition. Initially, prone positioning is utilized to improve gas exchange. He has frequent position changes and range of motion exercises done. After 5 days of careful monitoring and meticulous care, JT begins to improve. His oxygenation status stabilized, and is able to be slowly weaned from the ventilator. By day 7 in the ICU, JT is extubated and out of bed to the chair. Let's answer the following questions. The nurse is aware that JT's hemothorax caused ineffective gas exchange due to which of the following mechanisms? Anxiety due to the need for a chest tube, blood collection in the pleural space reducing negative intrathoracic pressure, pain related to chest tube placement, blood collection in the pleural space increasing negative intrathoracic pressure. So go ahead and review that, and then we'll go over the answers. All right, so our answer is B. While anxiety and pain could change depth and rate of breathing and contribute to poor gas exchange, the main reason is that the lung is deflated, impairing gas exchange. The blood's decreasing the negative pressure, not increasing it, leading to that collapsed lung. All right, here's a case study question 2. So the nurse expects to see what ABG results for JT when his ARDS begins to resolve. We're resolving. New onset respiratory alkalosis, an increasing PaO2 FiO2 ratio, resolving metabolic alkalosis, a decreasing PaO2 FiO2 ratio. So the answer is B. In a patient recovering from ARDS, we expect to see improvement of respiratory acidosis. pH is rising, PaCO2 is dropping. It shows us that the patient is again exchanging CO2 effectively. Okay, case study question 3. The nurse understands that JT's initial refractory hypoxemia indicates what about the adequacy of his supplemental oxygen support? It's sufficient and the FiO2 can be reduced. It fails to maintain adequate oxygen saturation. It has caused signs of oxygen toxicity and has caused alveolar collapse. So go ahead and try to answer that. Okay, your answer is B. Refractory means that in spite of increases of oxygen levels to the patients, the oxygenation status does not improve. Remember, we're throwing tons of oxygen at them, but it's not doing anything. Okay, case study question 4. Which of the following are priorities in JT's care? Select all that apply. Adequate nutritional supplementation, positioning with the good lung down, adequate hydration, maintain NPO status to prevent aspiration, or elevate the head of the bed. So you can pause it here if you need a little time to think about this. All right, answers are A, B, C, and E. Rationales listed there. So this client is, he needs to be mobile as soon as he's stable too. Bed rest isn't a choice. Remember, nutrition is important in this patient, especially trying to return to their pre-injury state. So if we position them with the good lung down as often as possible, this will increase the blood flow to the lung on that side and increase oxygen exchange. So also help with maximum expansion. And then we want to do hydration because it prevents venous stasis, maintains urinary function. We'll start some tube feeding with NG tube as soon as they're stable. And then we want to keep the head of the bed up to prevent that VAP, ventilator-associated pneumonia. Question 5. The nurse understands that the rationale for the administration of sedative and analgesic medications to JT while in mechanical ventilation is which of the following? So, improves respiratory effort, reduces pain, decreases oxygen consumption, increases patient ventilator synchrony, or increases mobilization. All right, your answers are B, C, and D. Sedation and analgesics are given for comfort. They decrease oxygen demand and improve the ventilator patient synchrony. So let's do just a few more review questions. The nurse anticipates which of the following in the initial care of a patient with ARDS? Inotropic agents, IV fluids, anticoagulants, positive pressure ventilation. So it's initial care. D. The first step in caring for a patient with ARDS is to treat that refractory hypoxemia with positive pressure ventilation. All right, a nurse is assessing a patient with multiple trauma who is at risk of developing acute respiratory distress syndrome. The nurse assesses for which earliest sign of ARDS. So what's our earliest sign of ARDS? Crackles, wheezing, bradypnea, tachypnea. Ooh, let me tell you the answer for this one. Okay, so the answer is tachypnea. So the earliest detectable sign of ARDS is tachypnea. It's followed by increasing dyspnea, air hunger, retraction of accessory muscles, and cyanosis. Breath sounds may be clear or may consist of fine inspiratory crackles or diffuse coarse crackles. Which of the following best describes what happens to the alveoli in ARDS? The alveoli are overexpanded. The alveoli increase perfusion. Alveolar spaces are filled with fluid, or the alveoli improve gaseous exchange. So take a minute to answer that, or 10 seconds. Okay, the answer is 3. In ARDS, alveolar membranes are more permeable and the spaces are fluid filled. Alveoli collapse and the spaces fill with fluid. So as they collapse, you have impaired gas exchange, and then the fluid interferes with and impairs perfusion and gas exchange. So, what are some major considerations for mechanical ventilation? List assessments, complications, and weaning. What are we going to do for weaning? What are major considerations? So go ahead and pause, take a few minutes to answer these questions, and then as you resume, you can hear me answer. All right, so major considerations for assessments. We want to make sure we're monitoring respiratory function, their oxygen levels, ABGs, vital signs, hemodynamic monitoring, a skin assessment, urine output, any chest x-ray results, and then, of course, do good assessments for their mechanical ventilation. So look at their settings, check the oral airway, and do good oral care. Complications, so we could get barotrauma, renal failure, or MODS, multi-system organ dysfunction syndrome. We could get a VAP, ventilator-associated pneumonia. Could have GI, stress ulcers, which we use wet protonics for that. And then weaning, so major considerations with weaning. It depends on a few factors. So the earlier the better. Weaning trials are completed at a minimum once per day, maybe even twice. It depends on the physicians. And then we want to make sure that we use the correct mode. So our SINV, or positive pressure for, make sure we use the correct modes for weaning. Okay, chapter review question 1. Let's see. So, a nurse is scheduled to take care of these 4 patients in a trauma step-down unit. Which one should the nurse assess first based on this information from report? A 19-year-old, 2 days post motor vehicle crash, stable on CPAP with rib fractures, complaining of chest pain, 7 out of 10. A 40-year-old, 1 day post-op, repair of ruptured spleen following MVA. He's ANO ×3, but slightly confused about how he got to the unit. 21-year-old, comatose, following a fall and flail chest, receiving mechanical ventilation and titrating a vasoactive drip for low blood pressure. 60-year-old with a left femur fracture following a farming accident who's experiencing new onset of slight shortness of breath. That's a hard one. Okay, answer C. So the patient C, you have to think what's going on in the moment and who is the priority, not what's potentially going to happen. So patient C has actual circulation problem. It requires few 5-minute vital signs while titrating these vasoactive drips. Also, we need to assess the stability due to his mechanical ventilation. Patient D would be next with that potential perfusion gas exchange problem, could be experiencing a PE. So a patient who is tachypnic for an extended period of time will demonstrate which of the following arterial blood gas results: respiratory alkalosis with hypercapnia, respiratory acidosis with a rising pH, respiratory alkalosis with hypocapnia, or no changes in the results due to metabolic compensation. Sorry, I did that too fast. Okay, answer C. Rationale: patient who is tachypnic for an extended period of time, what happens to them? They'll blow off quite a bit of CO2 with a resultant respiratory alkalosis. All right, question 3. The nurse caring for a patient with a closed pneumothorax will monitor closely for which of these complications? Tension pneumo, flail chest, cardiac tamponade, or pulmonary embolus? The answer is A. So a patient who's experienced a pneumo is at risk for a tension pneumo, especially if there's continued accumulation of air into the pleural space. In assessing a patient's arterial blood gases who is diagnosed with early stage acute respiratory failure, the nurse would expect to see which of the following results. I'm not going to go through each of these and read them, but I would say pause right now and then read through these and figure out which ABG you would find with early stage acute respiratory failure. All right, your answer is B. So in the early stages of acute respiratory failure, the nurse would anticipate that the client's respiratory rate is elevated, oxygenation would be decreased, resulting in respiratory alkalosis with hypoxemia. The nurse understands tracheal deviation in a newly admitted patient to the ED is typically caused by which of the following: hemothorax, tension pneumo, flail chest, or subcutaneous emphysema. Your answer is B. Tracheal deviation is a classic manifestation of tension pneumo. Okay. After you review, go ahead and take the ARDS practice quiz again. Your link is on Canvas, not Moodle. Also, you can go into Kaplan. I sent out that announcement on Canvas too. So there's lots of videos for you to review. There's a remediation video that's 14 minutes long that's on respiratory distress and ARDS. Also on the Kaplan channel, select those recorded videos and click on respiratory topics and you'll find more resources to help you review too. So that's all I have for our ARDS lecture. If you have any questions, please email me. Thank you very much.